Well, hello, good evening. On behalf of the Department of Communication and the University of Washington Debate Union, I'd like to welcome you to the second annual Gerry Philipsen Debate Forum. Last year, at this time, I stood up here and I told the audience who was here that this was like a really important occasion, that we were involved in founding a tradition here, creating a debate forum, an annual debate forum named for then retiring Professor Gerry Philipsen, and for establishing the concept of debate, a regular debate element as a part of our campus. I said then that last year that the founding of this forum marked a lot of important things. It recognized the incredible contributions of Dr. Gerry Philipsen to scholarship, to service to the University of Washington, and to his advocacy of debate as both an idea and a practice as a part of the educational structure that we're in. It also marked the return of student-driven policy debate to the University of Washington, which has not been an active campus program for 17 years and hasn't been officially supported by the university for quite a bit longer than that. So in some ways, last year's forum marked the reemergence of this kind of debate here on campus. Tonight's a similarly important occasion, and I promise that if you were to come back next year, it probably won't be a third just as important occasion. But tonight's similarly important because it sets in stone what we set last year. Last year I said this would be an annual forum that we did, a student-driven debate forum that we did, and now we've made it come true. The second annual time has made it a tradition. You do it once, that's just a single event marking the retirement of Gerry Philipsen, honoring him, that makes sense. But twice means that we have something special, that every fall the students who are involved in the Communication 334 and the variety of other debate classes that I teach will be a part of this unique event here. And so we put a seal on it tonight, and we confirm the Philipsen Forum as a testimony, as part of our department's commitment, as part of the UW Debate Union's commitment to debate as an idea and available to all students. The forum is sponsored by the Department of Communication and by the University of Washington Debate Union. Let me say a couple things about the Debate Union before we go. The Debate Union is a program of the Department of Communication at the University of Washington that's dedicated to providing a forum for civic dialogue in the community and for promoting intercollegiate debate competition. So intercollegiate debate competition means we go to other schools and compete and debate there. My name, most of you know me, but my name is Dr. Michael Souders, and I'm the director of the University of Washington Debate Union, as well as being a lecturer here in the department. It started last year. The Debate Union is a collection of students who dedicate themselves to the hard work of engaging in research-based debate against other universities around the nation and putting on campus events like this one here. It's an important and exciting addition to our university. And it's growing fast. 12 months ago today, as I stood here and was before this first debate event, we had a budget of 0 and only a few competitors who I'd only seen a couple times. At the time we had no budget, no competition, and this was going to be our first of ever event. Today we have about 15 members of the team, variously in and out of it. We have 2 coaches. We're adding 2 more coaches to our program. And we are traveling a full national schedule. So the program has taken off in a way that's pretty important and special. And we're taking on a lot more events on campus as well. It's not just students traveling to other events. We obviously put on the Philipsen Forum. We're talking about sponsoring ASUW debates as part of the elections there. We are sponsoring a high school debate tournament that I estimate is going to bring 300 to 400 high schoolers to the campus in February on the 13th and 14th. Yes, we're going to make high schoolers spend Valentine's Day here on campus. They're teenagers. And we're looking to put on a series of other public forums on things like transportation in the region and the problems that transportation has. And so that's a part of what we do. Already this year we've traveled to the United States Military Academy in West Point, New York. I traveled to West Virginia University in Morgantown. And also we traveled to the University of Puget Sound. But that's not very exciting because that's down in Tacoma. And while everyone else is resting on winter vacation, Some of the students here I'll introduce you to in a moment are already going to be headed down on January 2nd to the University of Southern California to compete. So that's what we're doing. That's what our program is, and it's growing quickly, and I hope that the people here will recognize that program. You might consider becoming a part of that program, and you might see this event as an extension of what they do. So I want to take a moment and introduce those students to you, and hopefully they'll stand up so you can see who they are when they call your name. The first person I'm going to introduce is, and I'll go through the names pretty quickly, is Zach McGearing. He's the president of the Debate Union. We also have Adam Anderson, underdressed. Is Davin Cocroft here? Davin, are you here? I didn't see him. Okay. Michael Elizondo. Dylan Green, who changed his name to Frank today. Is Felix here? Not here? Okay. Daria Mikovic. McKenna Maines. Rebecca Petroni. Tim Pollard. The famous Zachary Rashofsky. Nathan Sheely, who's our moderator for today. And Dylan Thomas, I think, is all the folks who are here with us today. So this is a group of people who have who dedicate themselves to working about 5 to 15 hours a week and giving up their weekends with no financial compensation just to go to represent the University of Washington and compete there. So I wanted to take a moment and recognize them. None of this stuff happens without support. None of this happens without a wide deal of support. In what is now my 4 quarters here at the University of Washington, I've been lucky to have extensive support from the Department of Communication, who, when I came in, promised me that we were going to do this the right way, that we were going to do this big, and they have supported me every step of the way. As we have produced more and more people interested in doing it, they've been there all the way. We've also had a lot of support from alumni. Our program is able to do what it does. We're able to make fine posters like the one out there, get food for events, food and beverages for events, travel, and a variety of other things because we have alumni supporting our program. Our program is mostly supported by alumni and not very much by the contributions of the university. And it's those contributions I really want to recognize. Events like this are free of charge. Our travel supported and our mission is supported because alums like Kirk Carlson and Propel Insurance, which is a regional insurance provider, lead the way in making debate possible at UW. That's how this functions. This team functions by almost no cost to you, both as students and as taxpayers, because those individuals contribute. I want to take a minute and give a round of applause to those groups before I go any further, because without their support, none of this would be possible. The forum is named for Dr. Gerry Philipsen, and I want to say a couple things about him. He's a professor of communication, and if you have been in this department, you'll have met him. He was here last year. He's an essential scholar of cultural communication, an innovator of speech code theory of communication, a former debater, an advocate of debate, former chair of the faculty senate, and even now that he's retired, he immediately became a debate coach again at Seattle Pacific University. Gerry's presence in this campus and in scholarship is immense, and I think that's something that is important to talk about. To put it in perspective, he won the Faculty Distinguished Contribution to Lifetime Learning 14 years before he actually retired. So that's the kind of award they give you when you're retiring, and then he taught for 14 more years in the university. Google Gerry Philipsen, and you'll see someone whose influence is extensive and powerful. You'll see interviews with him on television. You'll see interviews with him with leading scholars of the field. And if you ever have an opportunity to meet Gerry Philipsen, you'll find him to be one of the nicest people that you can possibly meet. I met Gerry Philipsen for only one semester when I came here. But when he interviewed me when I came here, and he was the first person I met at my faculty interview here, and we met for breakfast. And I was applying, of course, for the director of debate job here and as a lecturer faculty member. And his question related to this was, what 3 works of literature would you have all undergraduate students read at the University of Washington? That's a tough question. It seems kind of like a tail twister, the kind of question where you think to yourself, imagine yourself in the interview situation. Somebody asks you that question, your job depends on it, right? But it actually made a lot of sense to me. What Gerry wanted to know was what sort of person I hoped students would be. If I was going to be at the University of Washington, what kinds of things do I think students should be like, and how would I get them there by reading books? And something that wasn't what I do. What I do is this. But what about literature? What about other things that a university does? And it tells you a lot about Gerry, that he's interested in how the university shapes students, or should shape students. And we got along immediately. Although we didn't see each other very much, I was starting up this program and he was in the process of retiring. There's something about debate, intercollegiate debate, that really binds people together. So even though Gerry, who competed in the 1960s at the University of Denver, and by the way, knew Condoleezza Rice there, and I competed in the 2000s at Seattle University, even across those decades, debate simply made sense to us because it's an experience that bonded us together, similar to the way that debaters up here, after this experience, will know something about the experience of debate competition, and they'll remember what it's like to have to stand up there, knowing that the person after you is going to challenge your ideas. The something that Gerry understood is that debate is a unique tool of learning, and that it doesn't just ask you to know, but asks you to understand, to explain, to define, to refine, and to challenge and be responsible for what we know. It's not like taking a test. You don't get to regurgitate your knowledge. It's a little bit like you took a test, the professor says to you, now defend your answers, and your grade depends upon your defense. And that's a different kind of knowledge, and it's something that debate does uniquely. It's also a motivator of the essential structure of reasoning and education. What does debate ask you to do? A lot of you are involved in debates. Some of you are my students in here, and you're involved in my classes. Think about what debate asks you to do. It asks you to read. It asks you to reason, and it asks you to speak. The three basic skills of education are those three skills: reading, reasoning, speaking. Turn knowledge, absorb knowledge, process knowledge, spend it back out. And it asks you to do those all on their own. Ultimately, it's actually what lies at the heart of the university itself, this campus itself, what lies at the heart of the university. As one of my favorite scholars, a fellow named Daniel Robinson, says, and if you ever want to learn about Daniel Robinson, you can go by his teaching company tapes on the history of philosophy. That's actually how I know about him. He remarks that if someone asked you to come up with a single word in the past 1,000 years, that a single explanation for all of the innovation in the human sciences, in physical sciences, art, the humanities, literature, medicine, culture, law, it would be nearly impossible to make one word explain all of the innovations in those areas. But there is one word that he says isn't a laugher when you say it in that context, and it's university. Only the university drives innovation in every single one of those areas. Other people drive it in other areas, but only the university is the only one in which someone would not just immediately be able to brush it off. And what makes the university, according to Robinson, is debate. The free exchange of ideas, not necessarily the kind of debates we see here, but the free exchange of ideas, the refinement of those ideas in active dialogue and conversation, and the testing and advocacy of those ideas in an environment of academic freedom, what we think is the important right to say what you want. It's not sports teams or provosts or deans or even fraternities and sororities that make the university. It's the free exchange of ideas. And that's why this forum is so important. Gerry's understanding of that is what motivated, by the way, some of the people in here are in a class called Honors 230, variously titled, but the title that I think we settled on was Debating Over Issues in Race, Class, and Gender. And Gerry's concept here was that we could teach an entire class relying entirely upon debate. So in this class, there was about 2 weeks of lecturing, and ever since then, it's been student-driven debate every single minute since. Students drive the research, they run the debates, they run the conversations afterward. That class isn't my idea, it was Gerry's. It's his ideas that that debate could work to make not just as a product, not just as a skill we learn, but as a motivator of knowledge that made that class possible. That's why the forum is named after him. The forum itself is kind of a special thing. It's not. You notice that all those people who stood up, none of them are on stage right now. This is not the debate team showing you how well they debate. Instead, like Gerry Philipsen thought, debate was something that involves the whole campus, the whole university. And so we created this forum to give undergraduate students who aren't necessarily committed to traveling across the country to do all these things, to engage their mind in important and critical topics, like today's topic on physician-assisted suicide. The students up here today, outside their practice debates, have never been engaged in this sort of public debate before. We envision this as the unique opportunity. When you're in a debate class, what do you imagine yourself doing? You imagine yourself talking about topics, but you don't imagine yourself sitting in front of a classroom arguing with each other. You imagine yourself getting up in front of an audience, right? Doing things in front of an audience. We wanted to create the opportunity to do that. And that's why this event is important, because it's open to all students. And I'll tell you, it takes courage to come up here and do that. It takes courage to come up to volunteer for this. It takes determination, and it takes work. These 6 students have taken on that work. And I'll take a moment. I want to give them a round of applause, and I'll introduce them. So the 2 teams here we have represent the 2 different classes that I currently teach. One is the honors class that I discussed earlier, and the other one is Communication 334, which is Essentials of Argument. And 3 people on each side volunteered. We had more than 1 volunteer. We had more than 3 for each side, but unfortunately we only had spots for 3. So there were other people who were willing to do it, but were unfortunately not able to fit into it. So I want to introduce the people who are here today. For the affirmative team, and this is the order they'll speak in, we have Kayla Wheeler, who's intended major in Law, Society, and Justice. Raise your hand. There you go. Jared Moore in Computer Science. And Lee Organic, and I think it's hilarious, Lee Organic's major is Biology, Cellular and Molecular Developmental Biology. On the negative, we have Sydney Compton Rodriguez, communication major. Heather McBreen, communication and business. And Madeline Bloom, communication. Nathan Sheely, who's the parliamentarian of our, who appointed himself parliamentarian of our debate team. What's that? Well, you wrote the Constitution and you wrote a job for yourself, so and then you demanded people elect you to it. Nathan Sheely is our moderator today. He's applied he's a major in applied computational mathematical sciences, so he'll be doing that job today. So, thanks, Nate. We're lucky here to have Helene Starks, Dr. Helene Starks, as our respondent, and I think most of you are aware, since I've talked extensively about Dr. Starks. She's an associate professor at in the Department of Bioethics and Humanities, and an adjunct associate professor at the Department of Health Services at the University of Washington School of Medicine. She's also an alum of our department here, or what used to be the School of Communication, isn't that right? And so she is an example of where you can go with a major in our program. Dr. Starks makes an excellent respondent for this debate. Her research is on palliative and end-of-life care, and we were just discussing a few minutes ago that she wrote her dissertation on this very issue. And as a result of that dissertation, she's been involved in important events, such as a court case in Carter versus Canada in British Columbia, in which her dissertation research and her testimony was quoted as a part of the decision that was made to increase access to physician-assisted suicide. Did I get that correctly? Yeah. So we're honored to have Helene here, and I'm looking forward to her comments on the debate. So let me briefly go over the discussion, and we're just about ready to go. I know I've been talking forever. There are going to be 6 speeches. The first speech will be delivered by the affirmative. It'll go affirmative, then negative. The first speech by the affirmative will be 6 minutes long. The following 3 speeches after that will be 7 minutes, followed by the affirmative rebuttal of 5 minutes, and then the negative rebuttal of 4 minutes. They'll ask questions. You'll see the competitors ask questions during the debate. They'll signal their questions by standing up. The speakers will recognize those questions or not recognize those questions as they so wish. You'll hear Nathan gavel, and what that means is that after the first minute of speech, questions are permitted, and then they're closed at the last minute of speech. So that's what those things indicate, and he'll tap the gavel twice to indicate the end of a speaker's time. After the first 4 speeches, we'll have 10 minutes for audience questions. We will hand the first question to Dr. Starks and for as many questions as she so wishes at that time. After that, we'll open it to the audience, and you're allowed to address your questions to that. Then we'll follow it with a closing rebuttals, and we'll have Dr. Starks hopefully will give us her reaction to the debate and help and give us a professional's and a researcher's view of the topic and tell us how we did in some sense. So with that, I am going to scoot out of the way. I'm going to turn the debate over to the moderator and the debaters. And the first person we'll have speak will begin over here. Let me scoot this over. Not to last more than 6 minutes.
Thank you. When people think about dying, and their deaths specifically, they usually imagine an ideal situation. They imagine falling asleep and not waking up, peacefully going away from this world. They think of freedom from pain, being surrounded by their family, being mentally aware of their last couple days on Earth, that their treatment choices were followed, and they were able to resolve all conflicts that they had with family and friends before they are gone. We would like to give people the opportunity to have this ideal death because currently that is not a situation that most people experience, which is why we are affirmative for the resolution that physician-assisted suicide should be universally legalized. For the purpose of this debate, we would like to define universally legalized as legal in all 50 states. Though we do not necessarily need it to be a federal law, we would be completely happy with each state having their own individual law. Also, for the purpose of this debate, we would like to define physician-assisted suicide by looking at the Washington Death with Dignity Act. Some of the specifics in the Washington Death with Dignity Act say that the patient must be 18 years or older, you must consult at least 2 physicians, you must be terminally ill with less than 6 months to live, you must be mentally sound, and you have to ask for it twice outside of a 15-day period. All of these numbers and specifics are arbitrary and are up for change, but this is just the basic thing that we would like to look at because the purpose of this debate is not to debate the specifics of the law, but to debate whether or not physician-assisted suicide should be legalized. Yes?
How do you plan to protect the vulnerable against abusing the law that the depressed people cannot get PAS?
There is a study done in both the Netherlands and in Oregon that has stated that people of minorities and stuff like that are not more likely to be accepted or denied for PAS over someone else, including mentally ill people, once they have received treatment and seen as sound. In 2012, the National Hospice and Palliative Care Organization reported that 1 out of 4 families are not satisfied with palliative care and hospice care. I personally have had experience with hospice care because my uncle passed away from cancer 2 years ago. And I personally am stuck with the memories of him in hospice care and how he didn't remember me being around him. Also, to escape hospice care and other sufferings, without the option for physician-assisted suicide currently, people take their lives in very traumatic ways. For example, Craig Chauvinel, after 28 years of struggling with neurofibromatosis, decided his quality of life was too poor, and he had too many surgical procedures, and the thought of enduring any more was unbearable, and he could find no legal assistance to end his life. So on the night of September 1st, 2009, he swallowed 12 sleeping pills, put 2 plastic bags over his head, tied with elastic bands, and was found dead in the morning by his parents. Craig wanted to end his life legally assisted, listening to his favorite music, and be surrounded by his family, and our legal system denied him that dignity. Yes?
So you said that hospice is unsatisfactory at the current time. Are you saying that PS is an alternative to bad
We are not saying that physician-assisted suicide should be seen as an alternative, but we want it to be a choice for any patients that are terminally ill. As you can see, people are ending their lives without PAS, but through very traumatic ways. And physician-assisted suicide would allow for a more peaceful alternative and also open discussion regarding end-of-life care. Doctors and families could become more aware of end-of-life care options and realize the shortcomings of the present system. This would also strengthen doctor and patient trust, because a patient can go up to their doctor and let them know that they are having suicidal thoughts or that they would like to end their life, and that it'll help build confidence and trust within the doctor-patient relationship, but also between families to let them know that you are experiencing these thoughts. Because currently, if you go up to a family member and tell them that you would like to die, and even if you are planning it, they are considered co-conspirators in an illegal act, because killing yourself is considered illegal. The law currently protects similar procedures like do not resuscitate orders and withdrawal of life support. Physician-assisted suicide is no different. Withdrawal of life support is a much more active process than physician-assisted suicide, while do not resuscitate orders are more passive. Physician-assisted suicide falls in between these levels of activity, as the doctor is indeed prescribing the end-of-life drug, that life-ending drug, but the person ingests it themselves, and it is, in fact, their own choice, unlike withdrawal of life support. In addition, doctors must obey do not resuscitate orders, but they are not required to take part in physician-assisted suicide if it is against their personal beliefs. Peace of mind for the patient is one of the most important things, in our opinion, for these terminally ill patients, and we want them to be able to have the choice to end their lives as they would like, surrounded by their family, and have their last moments on earth be happy ones, rather than be in the opiate-induced haze in hospice care. That is why we are affirmative in the resolution that physician-assisted suicide should be universally legalized. Thank you.
Thank you, Ms. Wheeler. We will now hear from Sydney Rodriguez to deliver the first negative constructive, not to last longer than 7 minutes.
We are arguing against the legalization of physician-assisted suicide. We are arguing for the well-being and the continuance of life for patients based on the improvement of pain control, support systems, and palliative health care. Overall, depression is a main contributor to suicide, and there is a definite correlation between the two. Depression is not a natural, healthy state of mind, and it is aided heavily by outside influences. We maintain that it is natural and intuitive to want to survive and not to end your own life. A study by the Journal of the American Medical Association showcased a group of 92 terminally ill patients. In this study, depressed patients were 4 times more likely to have a high desire for hastened death compared to that of non-depressed patients, shown by a 47% to 12% discrepancy. They found that both depressed and hopelessness provided independent contributors to patients wanting to hasten their own death. Depression is a byproduct of the circumstance of receiving a terminally ill diagnosis, but depression can be completely treatable. Dr. Herbert Hendon released a book in 1997 entitled Seduced by Death. In this study, a group of terminally ill patients who were depressed and requested physician-assisted suicide were treated for were treated for depression, and after treatment, 100% of those patients no longer wished to follow through with the procedure. In addition to that study, the American Psychological Association says that depression is absolutely treatable when an individual receives competent care. Clinical depression and cognitive depression are 2 very different things. Circumstantial and cognitive depression can be caused by things like life-altering diagnoses, or even something as explainable as just having a bad day. Both of these can elicit feelings of sadness, stress, and hopelessness. Essentially, anyone can experience these feelings on any given day. If we legalize physician-assisted suicide, A temporary cognitive state will influence an irreversible decision. Yes.
Are you implying that depressed individuals are unable or to make decisions about their own lives?
No, we're not implying that. We're implying that depression is a main factor of suicide, and it's always they're most likely grouped together, and that we should explore all options to solve depression before making a hasty decision. Yes.
Does that mean if all options were explored to treat this depression and they still wish to continue, would you then be opposed to them continuing?
Yes, we would recommend better palliative health care. If we legalize patients are susceptible to outside influences like doctor, family, and societies. That is why it's our duty as a society to protect the vulnerable, because views of life with disability can influence decision-making. Physicians are less likely to recommend life-saving treatments to people with disabilities. A study done by Carol J. Gill, professor of the Department of Disability and Human Development at the University of Illinois at Chicago, showed a study that 34% of emergency care professionals would imagine they would not be glad to be alive with a high spinal cord injury and would also not support a life-saving treatment for themselves or a patient. This is consistent with the 273 Muscular Dystrophy Association clinic directors that found 41% would discourage ventilator use by patients by facing respiratory failure, citing poor life for their patients, poor life quality. If we allow the legalization of physician-assisted suicide, this procedure will disproportionately affect disabled and vulnerable patients. Yes?
Are you saying that a disabled person giving the same amount of information as an able-bodied person would be unable to come to an informed decision?
No. Bettering healthcare is our solution to legalizing physician-assisted suicide. Palliative healthcare focuses on providing patients with relief from pain and stress from a serious illness. The quintessential purpose of palliative care is for a patient to create control over their own care. Palliative care is a multifaceted option that involves pain management, familial inclusion, and a degree of spiritual and psychological counseling. No, thank you. Physician-assisted suicide is anti-health care. To legalize it would take away from any potential opportunities for palliative care to grow and improve as a field. Once an option, physician-assisted suicide changes the dynamic of the patient-doctor relationship. It puts unnecessary stress on the relationship, and when palliative care and finding other opportunities to create better health care should be the main priority. In states where physician-assisted suicide is legal, the nature of diagnosing depression is fluid and arbitrary. Assessment is not succinct and cohesive. Our opposition cannot prove that legalizing physician-assisted suicide is without risk based on the precautionary principle, which states to risk management that states if an action or policy is suspected of risk or causing harm to the public or the environment, the absence of scientific consensus that the action or policy is not harmful, the burden of proof that it is not harmful falls on those taking the action. In closing, from an article from Competent Care for the Dying Instead of Physician-Assisted Suicide by Dr. Kathleen M. Foley, states, physicians do not know enough about their patients, themselves, or suffering to provide assistance with dying as a medical treatment for the relief of suffering. Physicians need to explore their own perspectives on the meaning of suffering in order to develop their own approaches to the care of the dying. They need insight into how the nature of the doctor-patient relationship influences their own decision-making. If legalized, physician-assisted suicide will be a substitute for rational, therapeutic, psychological, and social interventions that might otherwise enhance the quality for life of the patients who are dying. The medical profession needs to take the lead in developing guidelines for good care of dying patients. Identifying the factors related to physicians, patients, and the healthcare system that pose barriers to appropriate care at the end of life should be the first step in a national dialogue to educate healthcare professionals and the public on the topic of death and dying. Death is an issue that society as a whole faces, and it requires a compassionate response. But we should not confuse compassion with competence in the care of terminally ill patients. Thank you. Just kidding, guys. If you can take this. Here, go, Rusty. Oh my God, what the hell?
I can figure it out.
I broke your mic.
We'll figure it out. No. They have to be clipped together.
All right, these.
Yeah.
My bad, bro. My bad.
Yeah, that looks good now. All right. I think this is okay. Can you guys hear me? I think, Professor Soder's kind of built us up a lot. Like, I don't want you guys to think that I'm too good at speaking or anything. Thank you everybody for being here. I know some of you were forced. I think I have some charcoal stains on my shirt from writing and whatnot, but we'll see if those stay. All right. I think I'm ready to go. Okay. As the affirmative, we believe that physician-assisted suicide should be legalized universally in the United States. The opposition has supposed that, we should be funding palliative care and that physician-assisted suicide, the legalization, will prevent further research. But in 2013, looking at the Washington State Death with Dignity Act, 173 individuals requested access to physician-assisted suicide. That's a really small percentage of the people that died in 2013. All of the rest of the people who are dying are still going to be involved in the end-of-life care, requesting hospice care. Allowing physician-assisted suicide is not going to prevent, further research on hospice care or end-of-life care. The opposition has presented a number of hypotheticals of terrible scenarios in which we shouldn't legalize physician-assisted suicide. But they're just that, hypotheticals. If you look at the Washington State Death with Dignity law, the Oregon State, look in the Netherlands, are there any cases? Have these hypotheticals happened? No. Legalizing physician-assisted suicide may constitute a risk. Yeah, it's possible that some of these things may happen. They haven't. And even if they do, the benefits far outweigh any costs. Allowing people the opportunity to control their own lives in a situation in which they face potential psychological trauma, great physical pain, living without really knowing what's going on, we want to give them the option. We want to allow for a better doctor-patient dialogue. We want to allow patients to come to their doctor and say, hey, I've been thinking about ending my life. They may not end up going through with it. That's okay. Their doctor may think, you're depressed. You should see a mental health professional. We think that's a benefit of physician-assisted suicide. It allows the patient to have more attention from their doctor, for the doctor to realize there's something going wrong. There's more that we could do. What are some alternatives? If people with depression that want to have access to physician-assisted suicide end up no longer wanting it after treatment, that's a good thing. They've come out better in the end. But they've come out better because they had the option. They had the choice for physician-assisted suicide. Yes, Cindy?
Wouldn't your improvements to the system be hypothetical as well?
They would be hypothetical if it were not for the fact that in Oregon for the past, I think it's longer than a decade, the physician-assisted suicide law, there are different terminology we use, like physician aid in dying, death with dignity. They boil down to the same thing. The Netherlands has legalized physician-assisted suicide for 10, 20 years. Nothing's gone horribly wrong there. It hasn't been a slippery slope. Furthermore, just on the topic of hospice care, I would like to talk about a study in the New England Journal of Medicine that a third of hospice care nurses in Oregon State had patients in the past 4 years who engaged in voluntary stopping of eating and drinking. These are patients who are reaching the end of their lives and are no longer able to decide for themselves what to do. They can't end their lives. They're physically unable. We want to give them the option for physician-assisted suicide. Yes?
Oh, sorry. To piggyback on your prior point, do you believe that the open dialogue with physicians is not possible without the legalization of physician-assisted suicide?
No. I think that the open dialogue could very well happen now. And I love the idea of a public health campaign to better alert doctors and individuals about end-of-life care. That sounds great to me. But that doesn't mean we shouldn't legalize physician-assisted suicide. I just think it means it's another reason that we should. There are many benefits from this. The opposition has merely pointed out, some of these laws are legitimate. The Washington State Death with Dignity law does not have to be the end-all, be-all. We can fix it in some ways. As Kayla said earlier, it's just a framework that we're dealing with. If we think that every individual that wants to have physician-assisted suicide should consult a mental health professional, okay, so be it. Yes?
In response to the Netherlands, what you said, how would you respond to the fact that euthanasia has been legalized there, as also, especially in the case of if you're chronically ill, you can apply for euthanasia?
Yeah.
Accepted there as well.
That's not what we're arguing right now. And still, the Netherlands still exists, right? Nothing terrible has happened there. So furthermore, we're arguing about physician-assisted suicide, not euthanasia. The opposition had talked a lot about depression. They said that depressed individuals, talking about depressed individuals and how this is somehow a reason that we shouldn't have better physician-assisted suicide. That's simply not the case. These individuals that request physician-assisted suicide simply need to be able to make an informed decision about the end of their lives. Physicians are pretty good about recognizing when an individual is not of that ability. This is why we have that framework. You have to consult 2 different physicians. That's a minimum. We would personally recommend more within a 15-day period. That's trying to get away from that situation in which an individual is depressed and wants to end their life now. The depression argument is invalid. It's just an argument to strengthen the safeguards that we have against these potential risks from happening. This hasn't been the case in any of the implementations of the law we've seen. Thus, we should legalize physician-assisted suicide and give people the choice for a more compassionate death. Thank you.
Oh no, I broke it already. It's like just like that?
Yeah.
Okay.
Not to last more than 7 minutes.
It is our position that legalizing PAS should not be an alternative to unsatisfactory palliative care. Rather, it would result in more disadvantages than advantages to both patients as well as healthcare. To begin with, there's a strong correlation between depression and suicide, as we previously stated. Yet, PAS standards claim that it protects those who are depressed, yet measures to prevent the depressed patients from having PAS are both evasive and flawed. In a 2007 study, where there were 0 of the 46 Oregonians who died by PAS were evaluated by a psychiatrist or a psychologist. Rather, those who are requesting PAS are evaluated by a questionnaire and a dialogue by the doctor. And most of the medical community agrees that this is an unsatisfactory system, as well as that it is incredibly easy to work this system. Also, you can currently request whatever physician you want and change physicians if you don't like the prognosis that they've given you. So this is too easy to work this system. Even if you're not suffering from clinical depression, you're very susceptible in this particular circumstance, suffering from a terminal illness, that if you're laying in a hospital bed, you're diagnosed with a terminal illness, you're very susceptible to depressive thoughts. Maybe not chronic depression, but loneliness, lack of support, hopelessness, frustration from a poor prognosis. It's a very natural byproduct of the circumstance. Yet one can argue for better standards. However, the arbitrary nature of depression is very important here. There's no mathematical equation to be like, you are depressed. And there are also radical deviations between cases and individuals as well. So it's very arbitrary and very difficult to pinpoint that.
No, thank you. The opposition says that terminally ill patients need to be more aware of shortcomings in healthcare as well as of other options. This insinuates that PS is an alternative to unsatisfactory palliative care, which we disagree with very strongly. This is a misrepresentation of palliative care. Hospice is a wonderful system in which they're able to provide comfort and care for dying patients and their families, as well as they do not. We're not for that we think people should suffer because they're in pain. We think that there are better alternatives and palliative care can be improved, and that's what we should be striving for. And this is the instance with emergency kits, which hospice is able to provide, so that patients, if they don't want to die in the hospital and they want to die comfortably at home, they can take those home with them, and there's medication, there's anything that they need to be comfortable in that instance. Yes?
Do you have any statistics on the number of patients that are able to or do take these emergency kits home?
I do know for a fact that the Journal of Clinical Oncology cites that 82% of terminal ill patients are very satisfied with their palliative care. No, thank you. Modern technology is also very able to control in pain control, and that if you're suffering from pain, that we should not look to death as the alternative. We should look to improving palliative care or seeking the optimal results which it can provide. Also, why would healthcare legalize a procedure that avoids palliative care and yet poses itself as an alternative? It is essentially opposite of healthcare. The opposition says that PAS will reduce messy and violent suicides, but this is not healthcare's responsibility. We should not justify suicide in making an accepted medical practice. You're familiar with the Brittany Maynard case. She was, in fact, the poster child she's become for PAS. She's romanticized it. She has a loving boyfriend, a wonderful family, a beautiful woman. She was on the cover of People magazine. Yet this is an unfortunate misrepresentation of suicide. You can exchange guns and ropes for pills and dress it up and put it on the cover of a magazine, but it's still suicide. And the story makes suicide look like a beacon of hope to those who are suffering. And this is not a healthy image which we would like to portray to society. The opposition says that the option of PAS gives patients the peace of mind that they can choose to end their suffering. But the option actually puts more stress on the patients and the family rather than solely working towards optimal care for them. It's never not a stressful situation or decision for the family to choose between, do we continue care or do we make a fatal choice for our loved one here? It also puts stress on the doctor and the patient relationship. There becomes a level of mistrust in this instance due to the fact that possibly the link between PAS being accepted medical practice could tarnish the image of the profession. Providing optimal palliative care also we see that we can deduce that this becomes not so much of a priority where it's legalized, such as in the instance of the UK, where it is an illegal practice. There are 185 hospice units, whereas in the Netherlands, there are only 3. And we can deduce from this that optimal palliative care becomes less of a priority where it's legal. Also, since the legalization in Oregon, uncontrolled pain has gone from a 30.8% to a 48%. That's nearly half the patients are suffering from uncontrolled pain where it's legalized. We can again see the effects of this. So while the affirmative argues that improved palliative care and PS can coexist, when we look at the effects of legalization has on healthcare, this is clearly unsubstantiated. Palliative care will suffer, and that's an unfortunate byproduct of the situation, which we need to avoid by improving palliative care instead. The opposition also says that DNR orders, or do not resuscitate, and sedation are legal precedents of PAS. However, those are passive, and PS is an active form of suicide. You're still actively choosing to end your own life, as opposed to a do not resuscitate order, where the patient does not actively, in the moment, choose to end their own life. PAS, based on that fact, PS too closely resembles a traditional suicide, and we can't justify a traditional suicide by making it an accepted medical practice. In conclusion, it is our position that PAS should not be legalized in the United States due to the fact that it ultimately does not allow healthcare to put its best efforts forward in providing optimal control of pain and suffering, and it is in fact the more compassionate position. Yes?
Is withdrawal of life support any less harmful to a patient than the ability to make a choice about his or her own life?
We feel that suicide should not be viewed it should not become a medically accepted practice in which that we're justifying it. And that's the precedent is more passive, we would say, than active in that instance. Thank you.
averages $135 a day, the approximate cost of 1 second, which you only need once. End-of-life care in the hospital is even more expensive than this. One out of every 4 Medicare dollars is spent on patients during the last year of life. This averages from $39,000 to $66,000 over the course of 5 years, if you want to expand it. In often cases, the $66,000 is greater than all the financial assets of the family combined. Without making the argument that human life has an infinite value, what options does the negative see for reducing the obscene and increasing cost of healthcare?
Our answer to that from our position is that while unfortunately prices are increasing in healthcare, this is a life or death issue, and we prefer not to put a price tag on human life.
Right here in the middle. Yes.
This is a question for the negative. Previously, you mentioned a study by Dr. Henlon, Seduced by Death. I was wondering what were the circumstances of that study, like for instance, where was it conducted and how many people were involved?
There is 10 patients involved. It was conducted in 1997, and I don't have a statistic written down for where it was conducted.
Thank you.
Do you have any questions for the affirmative?
So for the affirmative, given the history of the Death with Dignity Act in Washington and Oregon, do you guys have any information as to whether or not most people or all the people who get that prescription filled choose to end their life? And if not, do you have any evidence to show that having the prescription given to them makes them more likely to commit suicide?
Yeah, we actually do have a statistic on that. In fact, that's mandated by the state to be reported every year. In 2013, I believe it was 24% of people that were prescribed the drug and received the drug never actually took it. So that would indeed indicate that the sheer fact that they have this drug means that they were more of a peace of mind, and like I said, 24% never took it.
It means that the issue of whether they're really depressed is somewhat invalid.
In the back.
These are terminally ill people. I don't know if any of you have ever sat with someone who's terminally ill, but I have. As a nurse and as a sister, as a daughter. They will die. It's not a matter of life or death. It is death. So isn't this, and this is for both the negative and the positive, isn't this really an issue of control over your life and keeping the ability to have control rather than being totally out of it, because pain control means you are out of it the whole time in order to keep your pain down, versus getting the business done with your family, making peace with the family, and then going peacefully. So
Thank you for your comment. We completely agree with that. It's people in end-of-life care are pumped full of so many doses of morphine and other so-called palliative care measures that they don't really understand what's going on anymore. They are out of control of their lives, and they lack the autonomy that all of us here exercise right now. We want to be able to make the compassionate choice and give these people the option to end life on their own terms.
We agree that there should be the compassionate choice, but we agree that there should be good, better palliative care is what we should see, so that they...
Like what?
I'm not a medical professional. I wish that I was. I wish I had all the answers. But I think that we should be seeking the best care possible for these people. Their lives are very important, and so is their comfort. And I think that that's what we should be striving towards.
Over here.
What do you consider better palliative care for somebody who is in severe pain besides morphine or opiate drugs?
Maybe researching pain control that does not, like opiate, or that is not like doesn't produce the same state.
And we also, like, a component of palliative care is psychological and spiritual counseling, which helps to the overall state of well-being towards the end of life and allowing patients to become comfortable with their mortality. So we're advocating for that as well.
So I apologize. This is for the negative, and I'm just kind of going back on an idea. You mentioned that depression is invalid when talking
you mean
about...
the affirmative.
Affirmative.
Sorry,
Yeah.
affirmative. I apologize. That depression is invalid when talking about PAS, but you mentioned earlier that people seeking PAS are facing a psychological trauma. Isn't depression a form of a psychological disorder? So wouldn't that be classified under care?
Yeah, no, that's a totally valid concern. Really, what we're talking about is they're trying to escape the potential of the psychological trauma, as we've been talking about, and that's really like the I'm completely out of control, I don't know what's happening in my life, I'm taking so many drugs type of psychological trauma that we're addressing. And what I mean in invalid, Lee brought up this statistic that 24% of the individuals in Washington State that actually are prescribed the drugs for physician aid in dying don't end up taking them. It counters the idea that these people are severely depressed and suicidal, that they want to end, because the assumption would be that those people would end their lives as quickly as possible. Brittany Maynard is an example of someone who is not depressed and engages in physician-assisted suicide.
So earlier, my question's for the affirmative side. Earlier you mentioned that the legalization of PAS would strengthen the doctor-patient relationship. Do you think that the legalization of physician-assisted suicide will interfere with the Hippocratic Oath with which doctors pledge to do no harm to their patients?
Yeah, that's actually a really good point. I would like to make a couple of points on that. First off, the Hippocratic Oath is not legally binding. Second off, the idea of Hippocratic Oath is to do no harm. And in many cases, in end-of-life care, keeping them alive is the harm. Nowhere in the Hippocratic Oath has it ever said, you must keep this person alive at all costs. Sometimes do no harm means to let these people slip away, and as we argue, on their own terms. In addition, there's a new, the Hippocratic Oath that's currently being said in most medical schools says, I will remember that I do not treat a fever chart, a cancerous growth, but a sick human being, whose illness may affect the person's family and economic stability. My responsibility includes these related problems if I am to care adequately for the sick. We need to, and as the Hippocratic Oath says, we need to respect these people of their humanity and their wishes.
How would you implement the inaccuracy in a physician deciding, the inaccuracy of a physician actually diagnosing the lifespan of a sick patient? I mean, in Oregon, there have been people living for a couple years after they have been prescribed lethal drug. And in Washington State, sometimes people don't take the drug and they leave like 1 year after they are being prescribed the drug. And I know like miracle happens all the time, like saving couple lives definitely outweighs legalizing the act.
There is always room for error in any form of medical procedure ever, which is part of the reason that in the Washington state law you have to talk to at least 2 physicians, but like we said earlier, we would recommend even more than that. So there's always room for error. There are people all the time who doctors say, oh, they'll never walk again, and then they do. But the patient knows the risks, and the physician has to tell the patient of the risks. So these are informed decisions that they are making, and they know that there is a chance that the doctors could be wrong.
How do they make a good decision when physicians are telling them the wrong amount of time they can live?
The 6 months, first of all, in physician-assisted suicide, where it's just a guideline, and just because a physician may tell you you're only going to live for 6 months more, the idea is that at some point the individual has to decide for themselves. They have to weigh the costs and the benefits, and if they're already experiencing the sort of trauma and the lack of autonomy that may cause them to want to end life on their own terms, so be it.
But the way is inherently
No
inaccurate.
follow-up, please. We'll take one more question.
suicide, why would you decide to allow it to be a state-by-state basis? Why not federal? If it's so easy for a state to make the wrong decision,
yeah, that's beyond the
right
scope.
decision, and
Yeah,
patients would be jumping from state to state.
That's beyond the scope of this debate. This debate is about the intent of physician-assisted suicide being legal. That would be a very interesting topic to discuss in a different setting.
And we didn't specifically say that it had to be state by state. I actually said that we would be fine with it being either federally or state by state.
I thought you said it would be more effective. I'm sorry.
All right. So that concludes our audience questions. Who would like to?
I'll save mine for the end.
All right. So we'll move on to the affirmative rebuttal, which will be delivered by Lee Organic, not to last longer than 5 minutes.
Can you all hear me all right? Okay. We have an undeniable problem in this country. End-of-life care is insufficient as it currently stands. Hospice care can help, and that's evidenced by the fact that most people do not commit physician-assisted suicide in places where it is legal. Most people will still choose palliative care and hospice care, but sometimes that's not enough. In fact, of all of the people last year in Washington that participated in Death with Dignity, 86% were in hospice when they took the drug. 86% of people were in hospice care when they decided to end their lives. That does not tell me that hospice care is completely sufficient in addressing these people's needs. In hospice care and in any end-of-life care, dying can be a long and drawn-out process, and it's scarring both to the individual and to their families. And if starving oneself is an acceptable practice, why not allow these people to ease their suffering in a much simpler way? The processes that people die now, either by removing life support or by stopping their food and water intake, are long and drawn-out processes. These aren't decisions that are made and then immediately enacted in a peaceful manner. There is often great pain and great suffering. And as our opponents have neglected to mention, hospice care does not address this. They seem to see that hospice care is this great solution that absolves the individual of all pain, and this is simply not the case. What do we do then? Do we let these people suffer as they take themselves off life support or as they stop eating? No, we need to give them the compassionate choice to end their lives with dignity. And we're already very close to legalizing death with dignity already, as there are laws that protect withdrawal of life support. If doctors feel uncomfortable with death with dignity, they do not have to partake in this. However, when there is withdrawal of life support, when the patient requests withdrawal of life support, they must comply with that. This is an act that gives patients back control of their lives. This act gives patients the ability to say enough is enough, and I choose now what to do with my life. This act gives great peace of mind to patients. As I've said before, 24% of people last year didn't end up taking this drug even after it was prescribed to them and after they had it within their reach. This sense of control is one of the things that people at the end of their life seem to lose. I'm sure almost all of us have known somebody close to them that has died of cancer or died of a neurodegenerative disease. And it is heartbreaking to see them in their last days, their last months, sometimes even their last years, feel like they can do nothing for themselves, feel like they have no control over their lives. And this option gives people that control back. I cannot stress enough how important it is to these patients to have this option, to have this control. And in so far, there have been no problems with aid in dying in other states or other countries where this has been legalized. People are already ending their lives, not only by refusing to eat or ending end-of-life care, but also suicide rates among people with cancer are twice as high as the general population. And up to 8.5% of terminally ill cancer patients express a sustained and pervasive wish for early death. That speaks volumes. If 8.5% of people are essentially begging for death with dignity, how can we deny them that when there is no precedence? One survey of terminally ill patients found that 10% of patients reported seriously pursuing physician-assisted suicide. There have been many studies on this, and there is no legal reason and no moral reason that we should deprive these people the right to end their lives with dignity. We do not want another scenario where a man is found by his parents dead in his room after he could do nothing to die with dignity, die in a peaceful manner, listening to music on his own terms. This is an uplifting act, allowing for the option for minimal suffering, peace of mind for the patient and their families, allowing them to achieve closure in their last moments, and allowing them to pass with dignity. Everyone should have this option. We should be given the option to die with dignity. Thank you.
Thank you, Ms. Organic. We will now hear from Madeline Bloom to deliver the negative rebuttal, not to last more than 4 minutes.
Is that okay? Can you hear me? Cool. All right. Our position has maintained the steadfast belief that it is our natural instinct to survive. It is why you can't bite off your own finger and why you cannot drown yourself in water. Any desire to end one's life is the result of a depressive state. Hearing that you're going to die prematurely or in a traumatic way is bound to result in depressed feelings such as isolation, loneliness, loss of autonomy, as we've said before. However, these symptoms can be treated by adequate care. The pre-existing Death with Dignity Act has insufficient safeguards that protect depressed and vulnerable populations from applying. These include inconsistent diagnoses of depression and insufficient, and the ability of patients to self-select doctors. The thorough examination by psychologists or psychiatrists is at the jurisdiction of the primary and secondary care physicians, and therefore not mandatory in determining the psychological health of a patient. Our position believes that adequate palliative care and treatment for depression are the best options for terminally ill patients. The affirmative has not made a convincing enough case as to why society would be better with the legalization of physician-assisted suicide. They have argued that with its legalization, doctors would become more aware of end-of-life care opportunities and would stimulate better dialogue and better care in the future. However, physician-assisted suicide does not suddenly open up a window for this dialogue, and this claim is unsubstantiated. We hold the belief that physician-assisted suicide is essentially anti-health care and downgrades the potential for palliative care to grow. We hold the belief that there is always room for improvement in pain management and health care. However, this is not a phenomenon unique to palliative care. We also cited that the majority of terminally ill patients are satisfied with their current level of care. Our position holds a steadfast belief that PAS should be illegal on the basis of the precautionary principle. This principle states that it is our social obligation to protect the public from harm when scientific investigation has proven that there is possible risk. We have determined that the legalization of PAS is detrimental to vulnerable populations and should not be an alternative to bad palliative care. This completely sidesteps the issue that palliative care needs to be improved. The legalization of PAS also undermines the foundations of the medical profession, which are essentially to honor to do no harm. If physician-assisted suicide is to be made legal, in theory, there could be a physician whose entire practice is the distributing of life-ending medication to patients. The affirmative supports that PAS should be legalized on a state and not federal level. They cite the Death with Dignity Acts in Oregon and Washington. However, they believe that components should be changed. They recommend being consulted by more physicians and by different psychologists and psychiatric professionals, as well as the ability for patients to self-select these practitioners. However, they fail to offer a model that is completely free of abuses. On this basis, our position believes that physician-assisted suicide should be illegal. Legalization does not solve inadequacies of palliative care and has the potential to harm terminal patients. The affirmative argues that PAS protects the quality of life is counterintuitive. They believe that the quality of life is dependent on your ability to make choices. However, physician-assisted suicide ends all ability to make choices.
and that ability dies with the patient. We believe that doctors should pursue the best possible treatment in all cases. Inadequacies are not a reason to pursue death. The foundation of the medical profession is to do no harm, and the legalization would change priorities of healthcare forever and the relationship between doctors and patients indefinitely. Thanks. Oh, I didn't.
Here, let's give all the debaters a round of applause. So I now want to turn the floor over to Dr. Starks to ask questions or comment on the debate as she sees fit.
Well done, all of you. I will start with the negative because I am not fully convinced by some of your arguments. So I'm going to challenge you on a couple of things. If I'm understanding your argument correctly, you are asserting that everyone who is pursuing this law is depressed.
Yeah.
All right, I will do that again.
About that.
For the record.
Use both of these.
For the record. Oh. Yeah, right. It seems to me that one of the premises for your argument against is protecting vulnerable people, and that you're making an argument that people who are terminally ill are depressed, and that is something that we need to address specifically before we would allow this practice to move forward. Is that a fair assessment of your argument?
Yeah. We're not asserting that every patient who is terminally ill is clinically depressed, but we affirm that they are experiencing symptoms of depression as a result of their prognosis.
All right. So so that's an assertion that needs to be challenged, and you've challenged it in one way by saying there were a lot of people who never got a psychiatric assessment. But one of the things that the law asks people to do is to assess competency to give informed consent. And one of the issues that comes up a lot around this question of depression, and the reason why actually none of you have taken on the issue of language about the word suicide itself, but one of the pieces that's important about that is that it implies that you don't have decisional capacity when you're depressed. What's your position about ability to give informed consent with or without depressive symptoms? Is my question clear?
Yeah.
Okay.
Can you ask it one more time, actually, please?
Okay. So one of the issues with the law, and this is very specifically addressed in the language of the law, suicide, the word itself, does not appear anywhere in the legislation. And one of the reasons for that was a concern that people who are suicidal lack decisional capacity to give informed consent. Would you agree with that idea?
I'm actually wondering, why is it not included? If the definition of suicide is to actively take or choose to take one's own life.
Well, the notion is that it implies mental illness, and mental illness implies lack of capacity. Now, these are implied. They're not absolutes, but that is part of it. And one of the requirements of the law is that you have the capacity of mind and body. You guys didn't mention body part, but it's also part. You have to be able to give consent, and you also have to have the capacity to actually ingest medications and do that voluntarily on your own. So one of the issues that people raise a lot around the issue of depression is if someone is depressed, do they lack the capacity to give informed consent?
We got this. It's okay. Does this work? No.
Just put it in.
Hello?
Sorry.
You only have one of the two, the other mic.
Okay.
Like, by your head.
Well, it kind of works. Oh, thanks. Okay. Let me collect my thoughts here.
What our position was, what we were saying, was that as human beings, it is our instinct to survive, that everything that we do is fight or flight, or survival of the fittest. If a lion's chasing us, our adrenaline kicks in and we want to run from it, and that our instinct is to continue to survive. And what our premise was that
if that's not the intention, if you want to end your life, that potentially is not the healthiest state of mind that you're in, and that's very recognized. That's very understandable. If you're being diagnosed with a terminal illness, of course you're very susceptible to depressive thoughts, and that's very natural. And so what we argued was that that's what needs attention. Is we're not asking someone to, do their taxes, but this is like a fatal choice, and we think that people should be in the very healthiest state of mind possible.
Sorry, I'll just hold it
okay,
right here.
There we
go.
So I want to challenge that again, because I think one of the women, and you in the back, I think you're separating terminal illness from the rest of your life. And I think one of the things that's important to remember is we may have an instinct to survive, but when we are not going to survive, the game may be changed. And therefore, it's important to sort of think about, I think where I hear you trying to do is conflate depression and desire for hastened death when you are depressed, which is not the same thing as a desire for dying on your own terms because you're going to die anyway. And that's, I think, a distinction that's important to think through, because I think you're conflating, I'm depressed, I'm sad, and I'd also challenge you to find the evidence that says that terminal illness is associated with depression. It turns out that what I know of the literature is that the rate of depression in terminally ill people is no different than in the population in general.
I mean, I read several studies, but I guarantee that there's different studies out there. Yes.
We're okay without the microphone. I think it'll be smoother if we just leave the microphone alone.
Sorry. You mean I'm not doing a good job?
I think it'll be okay.
Okay, great.
Every time. So we'll just go without it.
Okay.
For the affirmative, you were making claims that the assisted suicide will lead to better communication. And I want to challenge you and ask you why, or what evidence, if you have any, that would actually suggest that. Especially if you want to rely on one of the arguments by the negative, that people don't have long-term relationships with the physicians who end up writing the prescriptions. So when you look at the data, it suggests that people haven't, unfortunately, not in alliance with the intention of the law, they don't have longitudinal relationships like they do in the Netherlands with their physicians. So what is the argument that this will actually promote better communication?
Yeah, that's a totally valid concern. People don't see their physicians probably as much as they should, or that it would develop a good relationship. It's just in those situations in which an individual goes to their doctor because they have to, under the death with dignity law, consult a physician about this, and they ask for the the ability to make this choice. If that doctor is say uncomfortable with the decision or doesn't necessarily agree with it, what the line of argument that we're going down is saying, in that situation, the doctor might present alternatives if they don't think physician-assisted suicide is the best choice, and this sort of discussion would facilitate one about other options for end-of-life care. That may not necessarily be the case in all situations, but we also think that it'll allow better discussion within the family. If an individual is able to talk to their family members about physician-assisted suicide, that too will create a better and in a more open discussion for end-of-life care that we think is conducive.
And another question for you guys is that you're actually advocating that this become more complicated for the people who are trying to use the law by seeing more people. And so I want to hear what your rationale is for that, because remember, these are people with terminal illness, and the 15-day waiting period was to try to address the issue of that you guys raise in a good way of let's not make a hasty decision. This is an irreversible decision. The 15-day waiting period is sort of the cooling off idea. But these are people that are pretty sick. And so if you're going to now make it that they have to jump through even more hoops to get permission to do this, what are you hoping to attain with that kind of extra protection?
Right, so our intent is not to enforce that there be more physicians consulted or anything like that. That was mainly said to address the negative's concern of the fallibility of the profession or other problems that may arise. It's not something I don't think we're actually advocating for.
Yeah, we're not arguing over the semantics of the the Washington State Death with Dignity Act. We're just proposing that when legislators meet to discuss these things, they might decide, oh, okay, well, 6 months to live. How did we come up with that number? These are things that can change, is what we're saying basically. It's not set in stone. It's the physician-assisted suicide nature, the core of it, that we're really arguing for. So we're saying that, it's
So back to the negative. What safeguards are there any safeguards that could be put in place that would assuage your worries about wrongful death?
That's one of our primary concerns. We did cite the precautionary principle that we can't think of any safeguards that would be adequate to prevent prevent possible abuses or workings of the system. So we are hesitant to legalize it as a result of our inability to think of any surefire safeguards.
So aside from the instinct to live and the worry about vulnerable populations, what's your greatest fear? What are you the most worried about with a law like this? What's the biggest harm that could happen that you would be the most concerned? I haven't quite heard that in a very concrete way. What's the thing that's really got you worried that might happen, that could happen with it being legal?
We did talk about the Brittany Maynard case also, and how that represents a very idealistic candidate for physician-assisted suicide. And one of our primary concerns is how this, it's legalized, like she went to Oregon to receive the prescription, and how this could elicit patients who are terminally ill but not necessarily thinking about physician-assisted suicide as an option because they saw it as a perfect death, but in actuality, the chances of having a perfect death are very slim. In general, it's a very hard thing to, guarantee a perfect death. And so we're concerned that it would elicit more terminally ill patients to opt for that option instead of seeking continued palliative care.
Are you out of questions?
Oh, I could go on forever, but I think I will leave it at that. I will turn it back over to the audience.
So we can turn it back to the audience. So what I want to do is, so we sort of have debated the issue, and what I want to do is, if it's okay, Dr. Starks, can I put you and allow the audience to sort of address questions to you, because some of the students have been researching the issue for the entire quarter, and other ones have been helping them prepare for the debate for a couple of weeks now. So, in some sense, we've been, I'd say, my degree is in rhetoric, not in bioethics, as it were, and so there's a little bit of, I think that they would like to, to some extent, hear an expert researcher's opinion. So let me turn it over, and if you have questions for Dr. Starks, you can ask questions to the teams too, but in some sense, let's drop it off of the challenging kind of questions and try for more investigative kind of questions. Does that make sense to everybody here? Okay, Tay.
Okay, I have a question for you. So I've been really wondering, in your experience, I'm sure you've probably talked to physicians, or maybe you haven't, but I wanted to know what their take on it is usually. If you have talked to physicians, what do they see, or what do they say on this topic?
So what I can tell you is that when the law passed in Washington, we tried to sort of figure out what kind of support we were going to get for people being able to do this, because access to it is an issue when the law allows people to opt out. So what we found is that there's sort of, as you might imagine, there's strong camps on both sides, as evidenced by these folks, where there are some people who are, dramatically opposed, and some people who are like, yes, absolutely, kind of on the principle of choice, not because they think that everyone should do this, but rather it's sort of like the arguments about choice versus the arguments about, yes, everyone should die this way.
I haven't heard anybody who said everyone should die this way. I think most people who make the argument who are on the pro side are about choice. But what I would say is that about 80% of physicians are like, please help me God, no one will ever ask me this question, because I really don't want to have to do this. They haven't actually decided, and so they're staying somewhat agnostic, because almost every physician that I have talked to said, right now my position is no, or I'd rather not, but I know that there will be there's the capacity for a patient to cross the threshold tomorrow and change my mind. I've had my mind changed about all kinds of issues because the person in front of me is in a situation that is either too much for them, or they're making good arguments for it, or something else. And as part of my physician-patient alliance, to be their advocate, I am willing to be changed in my opinion. So I think most people are hoping that it will never happen to them, and that's a fairly reasonable thing because most doctors, most of their patients aren't dying all the time. Yeah, does that answer your question?
Thank you.
We go back to Albert.
So that being said, are there certain physicians that are definitely in favor of always giving the choice? Are there particular physicians that perhaps will generally provide physician-assisted suicide? Do you know of any cases?
I don't know that I think there's a greater understanding about what's associated with the people who are on the no side than there are for the people who are on the yes side. So it's typically a moral conviction. It's kind of how people believe, and this is not just physicians, this is people in general, about where they stand with respect to sanctity of life, and where they stand with respect to who's actually got the agency to make this decision. So in a grander scheme of things, people are often saying, this is not a human decision to make. We don't have the agency to be able to make this decision, that's God's decision. On the other end, there are people who say this is the ultimate expression of humans' ability to make choices and autonomy and self-determination. So there's sort of people who are the doing side that believe that. For the physicians, I don't know that we have predictors of who's going to be on the yes side. I don't know that there's studies about that.
So I saw someone in the back corner with their hand up. Is that Red? Did you have your hand up?
Yeah, I was curious as to whether or not you had any experiences with any doctors that had, or heard any stories where a doctor had administered the drug and then maybe had any personal qualms about it or psychological issues, or are there studies as to that?
So there's I don't have direct experience with that, but there is a study out of Oregon that was an interview study with physicians, and I think they sort of talked about how it really challenged them in good ways and in very difficult ways, because it pushed them to a zone that it was way outside their comfort zone to make this decision. I think on the upside, what people say is that because it's such a powerful decision, it really makes them review their value system very carefully and think about what harm is, think about what control means, think about what the limits of those things are. They worry about being manipulated by their patients. It's very interesting since you guys mentioned that it's about control, and physicians like control. So in these instances, it's their patients are trumping them in the control battle. And that's very uncomfortable for them. They're not used to giving it up like that. On the other hand, they also talk about how it's life-changing insofar as it kind of being the most real moment, because this is the biggest thing at stake for them, is whether they are going to support this person doing something that they really wish they weren't in the middle of doing right now. But the fact is these people are dying, and they're trying to advocate for them to have the kind of death that they want. So they had to really explore those issues at a personal level, and could they live with themselves after the decision?
So, one of the things that the negative said was that physician-assisted suicide laws might hurt vulnerable populations, and I was just wondering if you had any evidence or experience with that, with the implementation in Washington or Oregon, where physician-assisted suicide might hurt people of low income or disadvantaged socioeconomic positions, anything like that.
So I have not seen any evidence for it. Some colleagues of mine did a study to try to look at this. I think you guys cited it as the study by Batten et al. What I can say from the flip side is that it actually takes an enormous amount of resources to pull this off. First of all, you have to be willing to go public with this as a request, which is not an easy thing to do. So in and of itself, there's already a lot at stake just going, getting it together to make the ask, because everybody knows this is a taboo topic and nobody wants to talk about it. So that's it. Then there are all the actual hoops that you have to jump through to get this to work. So you have to go and ask a physician. That physician might turn you down. If that's the case, you might have to go to another physician. Either way, you need to see two. Those physicians won't always make it easy for you to do that, so you have to find people who are going to be willing. People don't hang signs outside their door that says, talk about PAS with me. I'm, the little signs that sort of make this a friendly place to talk about tough things. Nobody hangs those shingles on their door. So they have to kind of work their way into seeing whether they can even have this conversation at all. The thing we do find is that vulnerable populations are among the populations who are the least interested in physician-assisted suicide. And part of the reason for that, at least among some communities, is I've been denied service all my life. Now I don't want to go in and ask for this. I kind of want everything. So there's a demand side. And what actually happens is the people who are the most privileged, or who are not privileged in the sense of wealth, but privileged in the sense of self-efficacy and ability to get stuff done. So that crosses income strata. That is not a wealth determiner. But if you are the kind of person who's been getting your way most of your time, you may be vulnerable in all kinds of different ways, but it's those kind of people that are the less than 1% that are actually pursuing this. So I think it depends on what we mean by vulnerable. You actually have to have your act together pretty strongly, because you have to advocate for yourself, because there's a lot of barriers to make this not happen.
Let's go right here.
So I heard on NPR about a year ago about people arguing that they should lower the age for physician-assisted suicide for even children that are terminally ill that are still going to die either way, or people even arguing that people that aren't terminally ill should still be able to have PAS because they're living a life where they're going to be in pain for the rest of their life. So I was wondering what the debate was around that and the arguments for it.
So going back to kind of that continuum between people who think it should never happen and people who think there should be no restrictions at all, those are kind of the two polar opposites. The law is always a compromise that sort of has to deal with some of the things in the middle. And so the compromises were age of consent, which is usually 18, because consent is fundamental to this process. You have to understand what your options are, and you have to understand that if you take this action, there is no coming back. So you're going to die. People need to know that. And they need to be able to say that. And they need to be able to weigh the consequences of their decision in that kind of a reasoned way. So consent is a big, huge thing. There are lots of ways in which minors give consent, and we emancipate minors, and we do assent for people, and there are certainly age-appropriate ways to do consent. And you can make the argument, and people do, that teenagers who are dying know they're dying, and they're typically, sometimes yes, sometimes no, more mature than their peers because of what they've had to deal with in their experience. So this question about the age of consent is, I think, one that people want to stay away from because they just don't want to go there. But that's the real issue about the age is about their capacity for consent. So that's part of that issue. The other part of your...
Oh, sorry, go ahead.
What was the second part of your question?
Allowing PAS for people that aren't terminally ill but are going to be living a life.
Right. So that is the compromise, I think, in the law, was that they wanted to make this about dying, meaning that if you're going to be dying anyway, then the idea for this is to allow that dying process to proceed in the way that people want it to go. And it's not that it's exclusive. So as you said, the majority of them are actually on hospice. So they've pursued those options. But there's something at the end that isn't working for them. Either they're done or whatever. And so that's the compromise that the law has made. There have been plenty of arguments to say that's arbitrary, that's discriminating. There are people who can't die because their illness isn't going to kill them off fast enough, and we should give them the option. But the compromise in the social dialogue has been to limit it to terminally ill people.
I think we'll have to make that the last question that we'll take for the night. I really appreciate everyone showing up for the evening. I want to give a round of applause and thank Dr. Stark for being here.